Okay, welcome everyone. Thank you for joining us for Updates in Pediatrics live stream. Updates in Pediatrics is a monthly live stream program which takes place on the third Wednesday of the month at noon. Participants will receive a link following the program today for an evaluation for CMA credit. You can also use the QR code that will be displayed following the live stream today. So I'd like to introduce our speaker for today, Dr. Axelrod. Dr. Axelrod earned her bachelor's degree from the University of Michigan and her medical degree from the University of Louisville School of Medicine. She then completed her residency in pediatrics at the University of Louisville and was in private practice for 2 years. She then completed a fellowship in behavioral and developmental pediatrics at the Weiskopf Child Evaluation Center and joined the faculty at the University of Louisville School of Medicine and was on staff at the Weiskopf Child Evaluation Center for 18 years. She was a professor in the Department of Pediatrics at that time. And in 2005, she went part-time academically and soon started Square One, a private practice related to child and adolescent development. In 2010, she stepped away from the university and now solely practices at Square One. Dr. Axelrod directed the ADHD clinic for 11 years before leaving the university and continues to provide ADHD lectures to the community. So I'm going to turn it over to Dr. Axelrod, who's going to speak to us about the management of ADHD.
Hello, and thank you for inviting me to have this discussion. What I want to talk about today is ADHD, my love of this disorder and how to help people. What I want to address today is I think that some people do question the diagnosis or think of it as a benign condition. So today I want to discuss the history of the diagnosis, the neurobiology of ADHD, and how symptoms can impair function. And then I want to talk about what we can do as pediatricians to help guide for a healthy, productive life for our children. I have planned plenty of time for questions and answers and hope we can have some sort of discussion in this chat-like setting. So what I thought we'd do to start are to discuss some of the comments I've had from my families and then elaborate on those to discuss the diagnosis of ADHD. One of them was, my doctor does not believe ADHD is a diagnosis. 2, I've been told my son is all boy. Another one is ADHD cannot be treated until my child is in elementary school. And the last one I hear a lot is my daughter cannot have ADHD because she's not a behavior problem. So let's talk about the first. The diagnosis of ADHD has been written in the literature, both in the medical literature and in the lay literature, since the late 1970s. It's been described as problems with attention or problems with focus that start early in life or defects in moral control. George Still described this as a volitional inhibition. And then we started in the 1920s with the encephalitis epidemic due to the flu. There were people who had developed significant impulsivity, distractibility, and attention. And so they thought this was probably a brain disorder. It was then noticed that even people without having the encephalitis also had these symptoms. So then maybe it was a minimal brain disorder. So the name has changed throughout the years. The symptoms have been discussed since the 1770s. In the 1980s, the diagnosis was described as attention deficit disorder, and in 94 as ADHD or attention deficit hyperactivity disorder. As we'll talk, I think the diagnosis, the name is a bit of a misnomer. In 2013, when the DSM-5 came out, the symptoms of ADHD were divided into 4 categories. 2 of which we will discuss mostly today, and they are the most commonly used diagnoses, and that is attention deficit hyperactivity disorder combined presentation and attention deficit hyperactivity disorder predominantly inattentive presentation. There is also ADHD hyperactive and impulsive presentation predominantly, or unspecified ADHD. So ADHD meets standard criteria for the validity of a mental disorder, which means that well-trained professionals in a variety of cultures and settings agree on the specific criteria of a diagnosis. And by the use of that diagnosis, we can predict problems, outcomes, and response to treatment. So let's talk about the main symptoms of ADHD. And we all know these. They're impulse control difficulties, and that's both behavioral and cognitive impulsivity. Which also can be called distractibility. There's poorly regulated activity. Again, some people might call that hyperactivity, but it's not hyperactivity necessarily. It means there's difficulty regulating activity to meet a situational demand. There's an impaired ability to sustain attention. There is profound disorganization. And then the last two are really, really important. The variability in task performance, someday you got it and sometimes you don't, and the emotional reactivity. And there's a lot being written about that as right now. ADHD is a chronic neurodevelopmental disorder. It is lifelong for most people, about 80%. What you may not realize is the mean age of onset of symptoms of ADHD is at 3.5 years. And so, you know, when we say mean, we say half present before 3.5 and half present after 3.5. Symptoms of the diagnosis change throughout development, such that physical impulsivity diminishes as we grow older, but cognitive impulsivity typically persists. And these symptoms cause global impairments, as we will discuss. So how do I make this diagnosis? What we learned in medical school is that diagnosis is 80% history. And that is really what goes on with ADHD. You have to have the symptoms that as we define them, in at least 2 environments. If the symptoms are present in one environment, then we have to reevaluate what could possibly going on, and we'll discuss differential diagnosis. We need to get a good history of presentation, how long the symptoms have lasted. We need to get a good birth history and look for risk factors. We need to get a family medical history because of heredity, and we'll talk about that. And we need to know past medical history and history of concussion or illness. That is very relevant for the diagnosis. The other things we use that are so important are questionnaires, and the BAST and the Achenbach Child Behavior Checklists and teacher report forms. Both of them have parent, teacher, and self-report. Both of them are about 120, 130 questions, and the teacher or the caregiver answers all those questions. We put those answers into a computer and compare their answers to for parents or teachers of others same aged, either boy or girl, so they're gender and age specific. Neither of these questionnaires give you the diagnosis of ADHD. What they do is they give you symptoms on where to look. So what are the concerns that the family may have, and what may help you think a diagnosis would be, which diagnosis would be most helpful? I particularly like the Brown Attention Deficit Disorder Scale we use for teachers and parents. This is more specific for ADHD, and actually even more specific for ADHD combined presentation, and that's combined impulsive and inattentive. Observation of the child is of course important. However, if you have 10 or 15 minutes in the doctor's office, you may see a perfect little angel because you don't know, that child doesn't know what size needle you're going to bring in, or it's a novel situation and they may be sitting there scared stiff. On the other hand, you may have a child who is petrified or truly impulsive and is climbing the walls. So observation is part of it, but not the most important part. So what else could it be? What else could these symptoms be describing? Well, In our society, and most societies too, we have to think of poor nutrition and sleep deprivation. How many of you, and I can't see hands though, but have children who go to sleep so terribly late for many reasons? One of it, which could be they're on their technology all the time, or the home environment is difficult. And sleep deprivation can cause impulsivity and problems with sustained attention, as can poor nutrition. Chronic illness and abuse we have to think about all the time. Absent seizures, you're certainly going to miss information and you will look inattentive and distractible. We also have to consider learning deficits, such as language impairments. If you have receptive language impairments, you're going to miss much of what is being said, and you may be presumed to be inattentive or distractible, and you may get fidgety. Same thing with processing impairments and learning disabilities, cognitive impairments as well. So the other thing we have to take into consideration is these other diagnoses share symptoms with ADHD: depression, anxiety, bipolar disorder, thought disorder, autism, or substance abuse. Now, that is not to say that you can't have ADHD with these symptoms. You certainly can, but you need to rule out the affective disorders or other disorders for appropriate treatment of children, and typically treat the affective disorders first. This is why I think psychological evaluation is so important. You know, I realize that I'm a tertiary care provider, and it's easy for me to get a psychological evaluation, and it's much more difficult in the greater community. However, there are ways to get psychological evaluation through the school system at no cost to the parent, and we can talk about it if you'd like. A psychological evaluation gives us a total gestalt of what's going on. It gives us the cognitive ability of the child, figure out how the child is able to problem solve, what their working memory is, what their processing speed is. It's a good emotional evaluation, and it's a good child interview that's going to last more than 10 or 15 minutes. That gives us a better assessment of what's going on with the child. So, is this a child who's considered all boy, or is there something else going on? Are we dealing with a world-class, nonstop, mind-numbing, make you want to hurt somebody pain in the neck? And there are some wonderful children who fit in that category. Again, the core symptoms, as we talked about: impulse control difficulties, poorly sustained attention and distractibility, poorly regulated activity, disorganization, poor or no ability to generalize information. That's a kicker. Diminished rule-governed behavior, and the other two that, again, I stress: emotional overarousal and variability in task performance. The symptoms of ADHD are caused by abnormalities in brain activity in the prefrontal cortex and its connections to the temporal parietal lobes, the limbic system, the striatum, and the occiput. There are abnormalities in the function of neurotransmitters, dopamine and norepinephrine. Why is it important that I let you know that these are the areas of the brain? Because the difficulties that kids have are the ones that are governed by these areas of the brain. This is the area of the executive function. It involves working memory, concentration, persistence, and organization. I like this picture. It shows you what we're talking about. So let's talk about the dysfunctions that we see. As we're having dysfunctions in the parietal lobe, we are affecting language. And children with ADHD have delayed development of internal language. Let me remind you what internal language is. This develops around 3 or 3.5 years of age. Isn't that interesting? Which is the mean onset of ADHD. The development with children at that age, 3, when they're playing, you'll remember they talk themselves through things. I'm playing with this doll and it's going this way, or mommy does this way. I have to walk down the step. I'm going to do this next. They walk through everything they're doing, and that helps them imprint what they're doing and plan it for the future. So internal language is essential for the normal development of reflection, contemplation, and self-regulation. Why is this important? Because it helps you with the ability to follow through with directions and rules, and of the ability to read social cues and social rules, boundaries, because you're talking yourself through those things. Again, it helps you with plans and making and rule following and to-do lists. And ultimately, the principles, moral principles are so important. We talked about parts of the brain, temporal lobe, for instance, which affects working memory. I consider working memory to be your auditory Velcro. It's the working part of working memory. It's what sticks. It's what sticks for right now, so you can help to plan for later. You may not remember everything right now, but you've put it into your mind bank to help you plan to act later. And it is for anticipation, visualization, internalization, and the ability to prepare to act. Time management is really bad with kids with ADHD. They tend to, if they have an appointment at 3, they start getting ready at 3. So they're almost always late for appointments and deadlines. They're ill-prepared for upcoming activities, and they have trouble pursuing long-term goals. ADHD is a developmental impairment in the brain's self-management, the executive function of the brain. This is my pearl. And what does this mean? Excuse me. Individuals with ADHD have problems with problem-solving abilities, ingenuity, and the flexibility to pursue long-term goals. This is greater, they have greater variability in task or work performance. And so when we talk about the hallmarks of ADHD, impulsivity, distractibility, sometimes behavioral hyperactivity, greater variability is high up on the list. And this is what drives parents crazy, because one day the kids got it, the next day they don't, and they can't figure out why. The deficits associated with ADHD are problems initiating work. They're unable to stay alert or in what they consider boring situations. Boring situations are non-immediately reinforced activities. So the kids seem daydreaming and fog, they're not connecting. They appear to lack willpower or self-discipline, and they need immediate rewards. So we all need rewards to do things, but these kids need it more. They need to be told what to do. Another very difficult problem for these kids is emotional reactivity. Kids with ADHD, individuals with ADHD, are 2 years behind their same-aged peers in emotional development. And this becomes really important when you talk about at what age can a child ride a bike in the street? When are you going to be able to date? At what time can you drive a car? All major milestones are governed by maturity, and these kids are behind maturity levels. They are more reactive with their feelings. They have the same feelings as you and I. We can get really angry, but most of us can hold that together and not scream and yell without control. What happens with these kids is they will be emotionally explosive, and then that's over. Everybody else is shattered, but they're okay at that point. What happens when these impairments occur is kids are always in trouble. And because they're always in trouble and they don't always know why they're in trouble, they feel humiliation and defeat. They feel like they're dumb. They become defensive because they're not sure exactly what it is that happened. And they may seem to lie about their behavior, and they may indeed lie about their behavior. Their self-esteem goes into the toilet. And these kids are at risk for affective disorders. Affective disorders are depression and anxiety. When we talk about, when we talk about, when you talk about executive dysfunction, we're talking about trouble breaking down complex tasks into logical and manageable steps. That helps you plan. Kids with ADHD put a lot of effort into their work, but it's inefficient work. Their organization is profound, and they're inconsistent in their academic achievements. Now, let's talk about how the family works. There is indeed a family incidence of ADHD. We have looked for genetics of ADHD, and there's really no 1, 2, 3 findings that say, oh, you're going to have ADHD because of this. But what we do know is if a child's got ADHD, about 80% of the time, someone else in the family has these symptoms. It could be Uncle Joe, Aunt Sarah, Grandpa. Someone is impulsive or distractible or had trouble maintaining their work in school. So these are the risk factors. It's really quite high. Also, if you diagnose a boy with ADHD, that boy's sister has a 15% chance of having this diagnosis, and that boy's brother has a 35% chance of having the diagnosis. This is a family disorder. And when you talk about chaos, there's internal chaos within the child, but there's external chaos as well. So we talked about the genetic factors, the inherited factors. There are other risk factors for the development of ADHD, and many of these you know. Difficulties during pregnancy, exposure during pregnancy of certainly alcohol, tobacco. We know with fetal alcohol-related disorders, these children are profoundly impulsive and have no common sense. And the exposure to alcohol certainly puts you at risk factor for having an ADHD diagnosis. Exposure to lead impairs the brain's function in the orbital frontal region of the brain, involving dopamine and norepinephrine, and causes these symptoms. Prematurity, low birth weight are risk factors, and postnatal injuries, concussions, encephalitis, meningitis can put you at risk for developing ADHD. So again, I'm going to reinforce that when you diagnose a child with ADHD, almost 80% of the time, that child will have the same symptoms through adolescence. And many of them, may it be 50 or 60%, will continue to have the diagnosis into adulthood. Doesn't mean, what I always say to families is, the brain continues to develop until age 25, mid-20s. And so maybe your brain will catch up and that the diagnosis won't be so problematic. But very often, 50% to 70% of kids who've been diagnosed with ADHD will maintain some symptoms causing some impairment into their adult life. That's pretty significant. And so that's why I say, when you work with a child with ADHD, you're working with a family with ADHD. And when you talk about consistency and persistence, it takes a lot of repetition to help the whole family's working memory to get the appropriate intervention. So let's talk about another type of ADHD. ADHD primarily or predominantly inattentive presentation. These are the kids who tend to be very well-behaved kids in the classroom. They can often keep it together during elementary school or high school, especially if they have good cognition. When the work becomes more problematic, they lose the ability to compensate. ADHD inattentive type does not have the classic signs of ADHD that we described as hyperactivity or impulsivity or poorly regulated activity, but they have significant problems with organization, persistence and efforts over time. The other part that was on the previous slide, they miss that, I like to call it their pilot light. that motivation, that internal drive is low, and it's very difficult for them to initiate interaction. And their motivation seems almost malignant that it's not there. We need lots of external motivators to keep them going. Again, these are well-behaved children, but they are having difficulty pursuing their academic goals. They're not performing to potential. They get further behind. And that internal passion that I just mentioned is not there. But then they become socially withdrawn, and they are really predisposed to anxiety or mood disorders. Now, on the previous slide, I didn't mention it, but ADHD inattentive type has the same incidence as ADHD combined presentation, and that's 2 to 3 to 1 boys to girls. And they all, ADHD inattentive type and combined type, respond equally well to appropriate treatment. So let's talk about the impact of the symptoms we've talked about. These symptoms impair the quality of life. They impair the emotional function and social functioning. These are kids who can make friends easily, but they have trouble maintaining friendships. They tend to be intrusive, they are desperate for friends, and they miss the social cues and don't understand social boundaries, and therefore kids are hesitant with them. They can also be so emotionally reactive that other kids can become wary of them. There are strong impairment in social functioning. That's just for the inattention and the distractibility. But about 40 to 50% of kids with ADHD also have learning disabilities. And so their school functioning can be very impaired. What we know as untreated, the quality of life grows worse in both physical, emotional, and school domains than compared to typically developing peers. So they have elevated risk for school failure, somatic complaints, antisocial behavior, as I mentioned, psychiatric disorders. They are at risk for accidental injury and concussion. They are at risk for suicide. And untreated kids with ADHD are higher risk for drug and alcohol abuse. And as a result, ADHD costs society hundreds of billions of dollars a year. Non-psychiatric medical problems that are common among people with ADHD are the following: obesity, allergies and asthma, diabetes, and sleep problems, particularly sleep-disordered breathing. When I first started my journey with ADHD, I always thought of kids with ADHD as skinny little things, but kids with obesity can obviously have a higher incidence of ADHD and may eat to help, who knows exactly why, but satisfy themselves. So once the diagnosis has been made, we need to talk about treatment. And treatment involves a multidisciplinary approach. We know ADHD is a neurobiological disorder. We talked about the dysfunction of neurotransmitters, dopamine and norepinephrine. And we know if we can only do one thing, then the treatment with medication is what we need to do. However, if you look at the research about ADHD, the most effective treatment, the one that caused the best outcome, is to use a multidisciplinary approach involving physician, mental health provider, and teacher. First, we have to treat the injury, educate the child and the family of what the diagnosis means. And again, ADHD is a reason, it is not an excuse. So I have these symptoms, yep, makes life a little bit harder, but the behaviors that you exhibit must be the same as any other child. Therapy interventions must be provided over long periods of time. probably throughout life for most of these individuals. And in doing so, we can adjust the symptoms and these individuals can lead productive lives. So let's talk more in depth about what treatment means. I add 4, I talk about 3. Education involves 2 things. Educating the family of what the diagnosis of ADHD means and who have realistic expectations, understanding that these children are often told no, 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 and they learn by being told yes. We need to consult with school personnel. I never want these kids to be thought of as bad kids or attention-seeking kids, but kids who have a neurobiological disorder that need assistance and need special school-based intervention to help them succeed. Behavior management counseling is critically important. We'll talk about that in just a second. And then the last part of intervention I consider is medication. So why do I push behavior management counseling? Remember, when we talked about the heredity of ADHD, most of our families have symptoms of this disorder as well. And so we need a coach to help guide family members to break cycles of learned behaviors and to help parents be consistent in the way they treat their children. Now, consistency, as you all know, is very difficult, but we want to be as consistent as possible with these children, with every caregiver. And when we talk about behavior management counseling, or when I do some behavior management, I'm talking about working with who's ever really with the child. So that's caregiver, grandparents. I want everyone to buy in to give this child the best treatment they need. Behavior management counseling and family counseling is effective in teaching ways to be consistent, as I mentioned. It teaches problem-solving techniques, but also it is a wonderful support for our families because raising children is hard and raising impulsive children is really hard. When do we use medication? As I mentioned, it's a neurobiological disorder, so it's very effective for treatment, but we use medication when the symptoms of ADHD impair function in at least two environments, and they are persistent. All subtypes of ADHD respond equally well to medication. And it's nice to know that the most commonly used medications for ADHD, the stimulant medications, are the best studied medicines in child and adolescent psychiatry. There are more than 200 controlled studies about these medications. Why do we treat? We treat so we can avoid things. We treat so we can stop accidental injuries and traumatic brain injury. We treat so we can decrease the risk for substance abuse. We treat so we can avoid the impulsive sexual acting out and teenage pregnancy. And we want to treat to help educational underachievement. The other thing that I want to make sure I mention, I forgot to put in my slide, is a lot of kids with ADHD escape to technology because they get immediate reinforcement. They don't have a lot of friendships, and so they feel they have friends when they play on games. And what we all know in pediatrics is that the more exposure to that kind of experience interferes with our learning and interferes with our ability to socially interact, and we lose the nuance of learning. And so medication can also help redirect that as well. That's a complicated topic for maybe for another time, but we should talk about it. So I want to spend the last minutes I have a good 10 more minutes, I believe, to discuss about medications. And I've written a lot about medications in here. We won't go over all details. But the most commonly used medications for ADHD include the stimulant medications, and those are the methylphenidates and the dexamphetamines, the norepinephrine reuptake inhibitors, atomoxetine and villoxazine, the alpha adrenergics, guanfacine and clonidine, and that we can use these in combination or singly. So let's talk a little bit about stimulant medications. Stimulant medications are the first line medication treatment of ADHD. And when you use it, about 70% of the time, a child will respond to the first medicine you give. Up to 90% of individuals with ADHD will respond to the first or second stimulant medication. So it's really very effective. Stimulant medications are the most effective medication for impulse control difficulties. What stimulant medications do is increase the synaptic extracellular level of dopamine and norepinephrine. So methylphenidate increases the production of dopamine and norepinephrine, and dexamphetamines increases their staying in the synapse a little bit longer. And it is speculated or postulated that the resulting increase in dopamine and norepinephrine is the basis for the therapeutic effect. Everything has side effects. What the beauty of stimulant medications is that they're fast acting. They're in and out of your system quickly. That's also the horror of stimulant medications. They're in and out of your system very quickly. But side effects are, can include appetite suppression, and this occurs 95% of the time. There is no evidence that long-term stimulant medications result in permanent weight reduction into adulthood. And typically, you do not need to do drug holidays. Sometimes you have to arrange eating. So when the child is hungry, make sure breakfast is a critical meal for these kids. You want to feed them after school. They need to sit with the family when they eat dinner, but they may not eat then. They may eat a little bit later. There are ways to modify that. Other ways of doing it is if you're on a long-acting medicine, perhaps you use an immediate release on the weekends if you feel their weight is not matriculating the way you want it to. There has been question about the decrease in adult height. There is still a lot of question about this. Right now, it seems to be that it slows the pace or the velocity, but not the final height. Although there are some articles that talk about losing 1 or 2 centimeters or up to an inch of adult height. Stimulant medications can cause sleep difficulties, sometimes sleep onset problems, sometimes early awakening. Usually we can work around that, and we can talk about that as well. It used to be thought that if you had vocal or motor tics, it was a contraindication for stimulant medications. That is a myth, and it is not true. Stimulant medications can be used very successfully with tics. Actually, sometimes the tics diminish. There are rare cases when we use stimulant medication and a tic will occur. Sometimes you take them off the medicine, this tic goes away, you'll try another stimulant medication, nothing happens, it'll come and go. You have to remember that the mean age of onset of the development of tics is 7. So that if you start kids on medication around 7, they develop tics. The question is, were we unleashing the tics earlier? That's the question. There is also a rebound effect for some kids as the medication wears off. At the end of the day, this doesn't mean they're on too much medicine. It means we might need to augment their dose with a supplemental dose. Any child who's on medication, any of these medications, need to be followed minimally 3 times a year, minimally. And you're going to monitor their growth parameters and blood pressure and pulse. Blood pressure and pulse can increase by a few degrees, usually 2 hours after ingestion of medicine. Now, I have a whole list of the methylphenidates. And it's important to know that since 2000, there have been 11, I think now 12 new long-acting methylphenidate formulations. What I'm going to say to you, I'm not going to go over these in details. They're all written for you. But what I suggest is that you become comfortable with 1 or 2 of these. And then if they don't work for the child, you can look at the other way they're absorbed. It's important to understand for long-acting particularly that what part of the medication is being absorbed when. And that's what I described in these few slides. And if you ask questions about what I like, I can tell you, but I think we just find what we're comfortable with. With the methylphenidates, there are a lot of options with oral suspension, chewables, or disintegrated things. I do like the methylphenidate transdermal patch. I particularly like this medication for older children and adults, those who are driving, because you can keep this patch on for all day. The insert says you take it off after 9 hours, but you can leave it on all day. And it's a steady delivery of medication, and it's very effective. The new long-acting delayed release, give the medicine at night, 24 hours, quote unquote, medication can be very good. I don't think it lasts 24 hours, but it does last most of the day. This medicine, the non-generic name is Jornay. I don't know if I'm supposed to say that, but it's a relatively new medicine, is really, really good for kids who have terrible mornings, who can't get it together. Then their impulsivity affects the whole family for the rest of the day. This can be a very nice medication. The amphetamine formularies, I've written it out exactly like I did with the methylphenidates. Many psychiatrists start with amphetamines as opposed to methylphenidates. We all find what we're comfortable with. In my population, I have found kids get a little more anxious on the amphetamine. Doesn't mean yours will, but that's what my bias may be. They are very good medicines and can be very effective. The non-stimulant medications we use if stimulants are not effective. And at about 20 to 30% of kids diagnosed with ADHD will not either respond to stimulant medications or will have intolerable side effects. Therefore, we want to use other choices. And they are the alpha adrenergics or the antihypertensives. Some data suggest enhanced cognitive functioning in the prefrontal cortex. Would be good if it does. We use these medications sometimes adjunctively for ADHD. We think alpha adjunct is how I do it. They can be used to treat tics that kids develop or kids with Tourette syndrome, but they're also used for emotional reactivity or impulsive aggression, particularly the gonfal syndrome. So the short-acting clonidine and guanfacine have not been FDA approved for ADHD symptoms, but can be used very effectively. The long-acting, as I said, think add-on or adjunct, and I add these on to kids who are very tough with emotional reactivity. Alpha adrenergic medicines can also be used very effectively for children under the age of 4. These are the side effects, and I'm going to go quickly because I think time is in essence here. The norepinephrine reuptake inhibitors, atomoxetine, vilazazine, a relatively new one, and bupropion. Atomoxetine and vilazazine are norepinephrine reuptake inhibitors. Bupropion is as well, but also inhibits reuptake of dopamine. Wellbutrin is used for older adolescents. It can be fairly good, not great, but if nothing else works, it's worth a try. Side effects of the norepinephrine reuptake inhibitors, atomoxetine, belly aches, nausea, vomiting, sometimes drowsiness or insomnia. I give this medicine at supper time, so these symptoms can occur in the evening and night, and you can sleep them off. It is important to know that atomoxetine takes 4 weeks to become effective, to the dot, 4 weeks to become effective. The newer norepinephrine reuptake inhibitor is vilazazine or Quilbree, and when it works very nicely. Both of these norepinephrine reuptake inhibitors were made in Europe as antidepressants. They were not effective as antidepressants, and so they've used them for ADHD and has, again, not as effective as stimulant medications, but can be very effective. I'm not even going to go over the tricyclics. They're a 4th line, and if nothing else works, they're going to go. If you have any questions, I'm happy to discuss. So these are our beautiful children. And we have to remember, although I've talked about all the difficulties that they have, these are charming, creative, and fun kids. I laugh all the time with them. They can hyper-focus on whatever they want to do and do incredible drawings or Legos or or drama, or they are enthusiastic, sensitive, and caring. Very social, at least initially. They have these wonderful gifts. So let me just go over the conclusion quickly. ADHD exists and is a chronic disorder with poor outcome if left untreated. It is a mental disorder caused by biological, neurobiological deficits. Comorbidity is high, and early identification is critical because the mean onset is 3.5 years. There are effective treatments, and they must be long-term. They include behavior management counseling, educational intervention, and medication, psychopharmacology for biology, psychosocial to promote prosocial behaviors. When we use medication, we want to cover full day, and regular long-term follow-up is important. It doesn't mean they need to see a therapist every week, every month, or a couple times a month, but every few months, someone to turn to. Times of transition, it's wonderful to have a coach for the family. So we treat our kids to see who they can really be. These are my favorite resources. If you're not aware of the parentsmedguide.org, it's the website for the American Academy of Child and Adolescent Psychiatry. It has wonderful information about ADHD and treatment. I have all my families read that before I consider medication treatment. The other organization, which is a must, is the CHAD organization, Children and Adults with Attention Deficit Disorders. It has an attitude magazine, I think it's monthly. They have a conference twice a year that's spectacular. For parents and professionals, I recommend it for anyone. I love that conference. These are other resources that are available to you. And here I'm available. Contact me onto our website. My email address is on my website. I'm happy to talk to any one of you. Dr. McDonald?
Yes, all right. Thank you, Dr. Axelrod. Some questions. What do you recommend when a child or teenager resists medication because they feel it blunts their personality or sense of enjoyment?
I think that's an excellent question. And I sit down and talk with this child in great detail. And we talk about the pros and cons of the medicine using objective data. And I try various different medications to see if they'll buy into it. I don't want anything to blunt a child. I don't want them to feel that they're zombie-like. I may decrease the dose or change the category of medications that I use. And I try to give the kids a contrast. And I'll say, let's try this for 3 weeks. Let's talk about it then, and let's see where we go.
Okay. And then for children less than 6 years of age or preschoolers with ADHD, after a trial of behavioral management therapy, do you prefer to start or add a stimulant or a non-stimulant, or does it not matter? And then what about insurance?
Okay, let's start. You can treat children below the age of 6. Even though it says no, you can with immediate release. I treat kids lower than 4, and if the child's profoundly impulsive, I think the stimulant medications are the most effective. I may use immediate release as opposed to long acting with those kids. I have much better luck with that. Insurance. You guys have more experience than I, because you see more patients than I. I fight with them, as do you. I do a lot of peer-to-peer. I will say to many of the insurance providers, if you're being the doctor here, I am documenting that you're being the doctor here. So what I often will do is I will try what the insurance will offer. And if it doesn't work, then I just fight them and say, this is not working. This is why. I don't know if that's helpful. It's hard.
Okay. Can you review recommendations for children on medications with interrupted sleep and early waking?
Yeah. Often I will use, let me try a couple things here, because I do various things. If you're using a long-acting stimulant medication, I would go to a shorter acting. So in other words, if you're using what is considered to be a 12-hour, I'd use something like methylphenidate ER 50/50 that lasts 8 hours. So the effect may go away a little bit earlier. I believe in melatonin. Sometimes it's very effective for some kids. I don't like kids on it forever and always, but I think using melatonin an hour before bed, turning off electronics minimally an hour before bed can be very effective. I do use the alpha adrenergics for sleep, clonidine and guanfacine. Those medicines can cause bedwetting. You need to be aware of that. Not frequently, but it does occur. Sometimes I'll go to immediate release as opposed to long acting. And we use a lot of behavioral interventions to help, with sleep hygiene.
And then can you discuss diagnosing girls and ADHD?
Girls are missed. Girls are missed. We talk, if you look in the old literature, it says, girls are 4 to 1, boys 4 to girls 1, and it's not. It's, pretty close 1 to 1 or 2 to 1. The impulsive little girls you're going to get, right? Because if they're physically impulsive and have poorly regulated activity and emotionally reactive, those are easy to choose and easy to treat. It's the daydreamers, the kids who just sit in their chair and they can't connect. So I think we need to be very astutely aware to parents who say, I have to repeat myself ad nauseum for this child to complete a task. I can only give one command at a time. We are giving repeated information. This child is in my face, constantly talking, chatterbox, but can't redirect. So those are the cues that I think of with little girls with ADHD.
Okay. And will you reiterate the screening tool you recommend?
The screening. Oh, yeah, sure. The BASC, B-A-S-C, the Achenbach, and the Brown child behavior, and the Brown ADHD form.
Okay. And then a kind of a follow-up on the melatonin comment. Reports are coming out that lasting long-term effects are no good with melatonin. Can you report on this?
I know. I don't know the answer to you. Yes, I have to be cautious, and I really don't want kids to use it regularly. You're right. I use it cautiously, but sometimes I have to use
it. Okay. At what age can treatment for ADHD begin? As in, like medication treatment? Medication.
I have treated kids at 3 or 3.5. You don't want to start with medication at that age, but I have particularly, who I think of dramatically are my kids with autism spectrum, who are so profoundly impulsive that it's even hard to know if they have a social communication disorder because their impulsivity is so profound. So those are the kids I will put on alpha adrenergics, very, very small doses. I usually start with short-acting guanfacine, sometimes clonidine, whatever the family can get. I may even have them, the compound pharmacy help me with that. So I will do 3. I know I don't like to put medicine, little kids on medicine, but sometimes we have to help them learn.
Okay. Do ADHD and DMDD correlate at all?
They are 2 separate diagnoses. They, when you have DMDD, you probably have a higher risk of also having ADHD. Interesting, DMDD may be a prelude to bipolar disorder. We don't know that yet. And the symptoms, early onset of bipolar disorder can be very similar to ADHD. So it's part of in a spectrum. I think you can see that together.
Okay. What is your opinion of genetic testing, such as GeneSight, to determine medication effectiveness?
I see GeneSight testing as an outline. So it tells me how a child may respond to a medicine, how they metabolize the medicine. it doesn't tell me which medicine to use. And my experience have been so far is there may be medicines that are on the green side that work, but there may be medicines that it doesn't tell you about side effects. So you put a kid on the medicines that are on the green list and the kids have terrible side effects. And then you go to the red list and it works even though it's not supposed to. So it's an outline. So what I say to my parents is, let's try simple things first, and that's have the expense of the gene site testing. If we are not successful, then yeah, let's go to the gene site testing and kind of evaluate this a little bit further and see if we can come up with a better answer. If they could come up with the test and say, use this, it's going to work and there's no side effects, I'm the first on the list.
All right. Is it uncommon to start to see ADHD in high schoolers when academics are more rigorous?
Yes, I say yes. I think you have to have a history before that. Some sort of, I mean, you may be an extraordinarily cognitively gifted young person who's been able to compensate. So I'm not going to say never, but I always want to rule out other things that are causing these symptoms. Drug abuse, for instance, depression, anxiety, chronic illness. I always think there's something else going on first. So I have to rule out absolutely everything else before I would consider the diagnosis of ADHD early at the onset of high school.
Let's see, last question. Once medication is started, do you have to take it forever?
Nope, you don't. You use medicine for as long as you need it. You know, when I started this 30 some years ago, I would put kids on medicine, assume they'd last forever. And as I've realized over the years, our brain continues to develop. And so I have many young adults who've been off medicine for a while. So what I say to families is, we put the child on medicine, we reevaluate 3 times a year. If after a year things are splendid, let's take them off for a minute. If after a week, whoa, this is not good, you put them back on. So generally speaking, kids are on it for long term, but not for nothing is forever.
All right. All right. Thank you, Dr. Axelrod. This has been very fun.
Good. Thank you. I've enjoyed it very much. Thanks for asking me.
Great. So I just remind everyone, you'll receive a link to an evaluation for CME credit